Well, excited to be here. Thanks for the introduction and talk a little bit about what I'm sure a lot of health centers went through during this COVID transition. So like Danelle said, I'm going to be talking about some of the ways that we managed our dental workforce here at El Rio during the COVID pandemic. And I've kind of broken it down into 3 phases from our very early stages onto kind of the middle of the pandemic, and then kind of now what we're doing now and going forward. So looking back, kind of phase 1 and that, middle of March 2020, basically we had an overnight reduction in our clinic needs. I think it was around, March 14th or so. We moved to totally emergency care only in our dental clinics, and we made the tough decision to close down 3 out of the 6 dental clinics and kind of put everyone more together, consolidate all of the clinics down. We had about 150 employees working at that time, dental providers and dental staff, and we really only needed about 50 people in the dental clinics. And so it was a large reduction in the dental workforce that was needed. We had a couple of goals when we were making our consolidation plans, and that really was just to keep our employees safe, of course, healthy, and also keep them employed. So we had to think of some kind of innovative ways to do that. As we all looked into needed new PPE, it became apparent that our dental providers were really had the unique opportunity to be experts in PPE. We were used to wearing it on a daily basis, not as much as we're wearing during COVID times, but a close amount. And we were used to having to don and doff it between procedures. And so we mobilized some of our dental providers and dental staff to go across to our dental or other medical sites and talk to our other providers and staff about appropriate PPE usage, how to don and doff it. They demonstrated their skills and their knowledge. The other area that they became very helpful in was finding places to order the PPE during those kind of early times of struggle where it was hard to find. We already had some known resources of where we could buy things, and so that was very helpful on a clinic-wide level. And it was unique too because our dental team really had a chance to be the experts for a lot of our medical teams. Of course, we had to start doing patient screening across the health center. This was a new necessity, so we trained our staff to ask appropriate medical questions. We had people triaging on the phones before people would come in for sick visits. Of course, we were doing, temperature taking and asking a series of questions. And it allowed our team to kind of play a role in the medical field and get a little bit more familiar with kind of some basic triaging needs. And of course, this extended to our dental side as well, where they started triaging some of our emergency patients before they would actually come into the clinics. Along with doing the screenings here locally at El Rio, it was pretty neat. We El Rio partnered with Tucson Electric Power and provided the employee screenings for TEP. And since they were an essential business and had to be open all the time, they needed their employees screened at all different hours of the day. So we had different teams of dental staff that would go out starting at 4 in the morning and lasting until pretty late in the evening, screening the different TEP employees. It was a great partnership. It allowed some of our dental team to really get to know some other community members and kind of make us a little bit heard in the community. So it was great. And then we kind of enter phase 2, and this is kind of twofold. It's a double phase. So in August-ish, we started to see some kind of improvement in our numbers, and we really thought that it was probably time to start returning to some routine care. We brought in a little bit more hygiene care. We started doing some more restorative in the clinics. And we started to have more providers kind of back and working. We started to see our pediatric patients again for routine care in the clinics. But then around November, as I'm sure everyone remembers, we just started to see this huge increase in numbers in the community, both at large in Arizona, the nation, and, even locally with our patients and employees at El Rio. So it became apparent that we again had to shift our needs, and we had to reduce what we were doing in the clinics again and shift how we could help our health center at large. So we started having our dental teams help with the COVID testing community center and also the results. So we actually had dental hygienists and some of our dental residents trained. They were doing the actual swabbing of patients and testing, and helping with consenting and kind of running the community testing center. And then after that, we taught our staff how to actually receive the test results from the labs, call the patients and give results, and also give counseling. They help to manage their follow-up care, get them scheduled for telehealth visits in the clinic, and also check up on our patients that were kind of higher risk, and we were trying to avoid having to have them, go to the hospitals. But we really, it was a great lesson in coordinated care and some new learning for our dental team. They picked up a lot of medical knowledge during that time and what they should ask for when talking with patients, and also dealing with, fairly sensitive information. We were calling hundreds of patients and giving positive results, which was emotional for some and involved a lot of, follow-up questions. The other area that this was great was that it helped increase the staff knowledge on just using the electronic health record. We're so used to working in the dental record, but not so much in health record. And so learning how to actually receive results from the lab and put in notes in a health record was great for some integrated care. We also implemented a strong tracer program. So this was twofold. So part of it was counseling and contacting close contacts for people who did test positive and setting up testing for them, assuring them, giving them counseling. But the other part of the tracer team was doing some environment of care tracers throughout the clinics. And so we had dental providers and staff set up to go out to different clinic sites. They would kind of quiz people on how to handle different patient situations, assess the use of appropriate PPE, ask about workflows. And this really helped to make sure that everyone was on the same page. As a large health center, we were rolling out new changes on a daily basis, and that communication could be challenging, but going out and having these tracers and just making sure everyone was on the same page was really helpful in making sure we were prepared and managing our risk. Another thing we set up was this rapid response team. And this was run primarily by some of our hygienists. And even now, I just saw a survey from the American Dental Association that said, I think 1 in 16 hygienists that were working previously are still not working. So about 6% of the hygienists they surveyed. And so this was a great way for our hygienists to stay employed and help us out. The goal of this rapid response team was to basically go out in an in-person way to an affected clinic site where someone had tested positive. And the goal was to get out there within a few hours or at least the same day of the notification of the positive test. And they would speak with groups of employees that were affected, give counseling, set up large-scale testing for employees, and provide needed outreach. The health center, I'm sure you guys know that, when you have one person test positive, it can affect a large group when you're working in close quarters in the dental team. So it was really important for this rapid response team to be available for us. And then now we kind of moved into phase 3. So I would say around January of this year, we kind of have seen this return to care. And of course, the availability of the vaccine has been very helpful in our return to normalcy. I saw a report from the ADA that released that I think it said 88% of patients that they surveyed were ready to come back to the dentist or have already gone back. So this is a new time of preparation and getting people back in, excited to resume their dental care and assure them that it is safe to do. And as we all know, vaccines are are the way to this return to health and normalcy in the community. And so that's been an important part of this phase 3. So first, we have a lot of patients that want to come back into the clinics. They want to resume their dental care, but they're just really not sure how to do it or if it's safe or when they can even get in. Some of them are dealing with, delays in care because our schedules are pretty tight, which I'm sure some of you are also facing. We have this huge, backlog of patients that's now trying to get back in. We've had some that, missed appointments, have emergent needs, have had these long treatment plans that have been delayed. And so helping these patients deal with their delays in care is really crucial. So we have a whole team set up that's doing patient outreach, doing phone calls, especially to those at-risk patients that really need to get in and follow up with their care. We're using our portal to message people and just communicate in a variety of ways. Another way that we're helping in a new way is we're really mobilizing our dental team to help encourage and offer the COVID vaccine. So we've set up that patients that are being seen in dental can actually get their vaccine the same day as their dental appointment. We have our front desk trained to ask questions about if they've had the vaccine, ask if they have any questions. We also have talked a lot with our dental providers about their role in counseling patients and encouraging it. There was a JADA article recently that I think said more than 50% of parents, this was a survey regarding parents and children, but more than 50% said that a healthcare provider could for sure influence their decision to get the vaccine. And so we really play a crucial role in counseling and encouraging that. This has really, optimized the workflow for the vaccines to offer it either before or after their dental visit. It's co-located in the same building, so patients are willing to stay and get it. It's very convenient for them. And so this has been really encouraging for patients. We also have drive-through vaccine clinics still going on. And so we've really needed the manpower of our staff to help run these. So our dental staff is still really involved with just moving the cars through, getting the consent, making sure it's nice and efficient, prepping the patients, walking around in the parking lots and making sure patients are feeling okay for the wait time after the vaccines. We haven't started having any providers or residents or anyone actually give the COVID vaccine. That hasn't been a necessity, but we know that that's also a possibility that's been approved during this pandemic as well. So I think the, key successes and lessons, takeaways, I guess, from this time has really been that it was really an amazing time of teamwork and collaborative care. We were able to provide this really, coordinated care in an integrated manner, worked interprofessionally across the organization, and it all happened very rapidly and in a pretty amazing way. So going forward, we know that, integrated interprofessional care is important for the future. And as community health centers, we are in a unique arena to be able to provide this really integrated experience for our patients where they can get all of their needs in one area. But not only for our patients, but also for our employees. And this really just showed that there is the ability to kind of stretch the minds of some of the dental team. They worked together because they had to. There was no other way out besides working together as a team with different staff members that they had never worked with before in different areas that they were really unfamiliar with. It opened their eyes to some new knowledge, and I think it helped to realize some of their strengths as well, and it was good to push them a little bit. It kept them learning, it kept them interested and engaged. And I think a really kind of nice silver lining out of it was that some of our staff members have really expressed interest now in learning some different roles, becoming more involved with leadership, even looking into, health center operation level management. So I think that's been a really nice thing for our employees. And obviously, community partnerships remain super important, and just staying aligned with the community. We saw that with partnering, like I said, with Tucson Electric Power, and then of course with Public Health Department, all of that, and just staying as a leader in the community is super important. So those are some of the ways we kind of dealt with the pandemic, and we look forward to using some of these lessons as we move forward, and knowing that, not only during pandemic times, but also, we've kind of looked at, sometimes we have lulls in the clinic during the year. For example, like in our pediatric area, we always have kind of a couple weeks when school gets out, or in the summer we're a little bit slower. So we know there's different ways that we can keep our staff engaged and happy and working and still learning, even if it's not directly at the dental chair. So thank you for the opportunity, and I look forward to hearing from Dr. Wilcox here in a few minutes too.
Thank you, Dr. Pinder. That was great. Really looking forward to getting to Q&A. But first, we'll hear from Dr. Wilcox, and then later we will take questions. Dr. Wilcox, did you need me to bring up your slides, or did?
No, I'll give it a whirl here.
Okay.
We're having a little bit of technical difficulty, but we'll sort it and then run with it. Did that come up okay this time, Danielle?
It's still doing the other view.
All right, well, we'll just run with it.
It works. Yep.
Oh, brother. All right, so I'm Bruce Wilcox. I'm the dental director at North Country. I've been on board here about 5 months when COVID started. And like with everybody else, it's been an interesting challenge. Danelle, is that popping through? I'm not getting my slides to change.
I think it keeps adding a new slide. You might have to use the arrows instead of pressing.
Yeah.
Enter. Yeah. So maybe if you use the arrows.
So do you have standard view there?
It's still in that slideshow view where we see the list on the left, and then.
Oh, okay. All right. Well, we'll just click through. Apologies for that. I've got a nice big screen showing me the first slide, and it's not changing. So as most of you know, probably the initial recommendations from the CDC were to do no non-emergent care and defer all COVID positive care. The revisions to dental recommendations were happening about once every 2 to 3 weeks. And after a return to providing non-emergency services, there was changing and contradictory, I felt, recommendations that came and went. At one point, despite saying, we could be open for care, that any aerosol producing care was supposed to be done within the hospital setting or negative pressure rooms. So we decided that one of the first things we need to do is come up with a dental aerosol producing hierarchy. Ultrasonic scaling is supposed to be the most aerosol producing thing that you can do in all of healthcare. Obviously surgical procedures where we're cutting bone are pretty high, and then fixed prosthetics, standard restorative fillings, surgical procedures without bone cutting or tooth cutting, and prophylaxis. I have a little spot there that says spatter versus splatter. As I dug into some of the science behind this at that time, one of the first things that came across was that spatter and splatter are similar but different. Spatter's small particles and splatter is larger particles. And prophylaxis, while it produces a lot of splatter, does not produce much spatter. And so standard shielding is probably effective against that. Exams, then things like denture work at the bottom of the list. So by about the end of August, the CDC had settled on some recommendations for engineering controls. We were a little ahead of this, but it settled to close to the same thing. So first, having a closed room if possible, revision of HVAC where feasible to create an airflow from the hallway side to the end of the patient room, so that airflow wasn't flowing from the treatment room out into the hallway. Additional air processing using portable units to increase air changes per hour, and rooms left after use for 15 minutes before re-entered to clean. Initially, this was a standard recommendation, and then later it was changed to only doing that for suspected or confirmed COVID cases. So as of the last update, which is December 4th, the key points at the top of the dental chapter are that you recognize dental settings have a unique characteristic that warrant specific infection control considerations. Prioritize the most critical dental services and provide care in a way that minimizes harm to patients from either delaying care or harm to patients or personnel from exposing them to a risk of infection. Proactively communicating to personnel and patients about the need to stay home if they're sick, and know what to do if you get someone coming into the facility that has COVID. And I think two of the main things that really we think about now and think about going forward is, first of all, considering if elective procedures should be done at all. Should they be postponed, either all the time or for certain cases? But balancing against that is the highlighted part in the next phrase, which is, we're causing problems by delaying care. The longer people don't have regular dental care, the more that we get problems building up. We had a discussion in our DNPC group, DPNC group last fall, and people had a lot different approaches, and I don't know that anything's out of order here, but it is interesting to note that those that were doing the work, some had done a lot with engineering controls. Some were doing every other operatory for open bay areas just to keep apart. And some suggested that, hey, if the provider feels safe, then let them go ahead and do the procedure. What that really understated for me was that we were lacking a clear universal standard, and really still do. If COVID pandemic is over, what's the standard? If we're still in some sort of pandemic, what's the infection control standard, and what are our standards for engineering controls to mitigate those infection control risks? We engaged with a local company here that does a lot of medical facility building and just a big contractor here in Flagstaff called Love and Contracting. And they also brought in from Phoenix engineering group that they work on when they're designing hospitals called IMEG Engineering, to evaluate our current status, to make recommendations what we should do with our engineering controls. And the first idea just out the door was, well, we could put fans to recycle air in every window, but that's going to get pretty loud, but it would make you better able to work. So we dove in, had some lengthy discussions. They did some design work and then presented their recommendations. And one of the first things that happened as we dug in is that we found out, I wasn't aware, most of the staff weren't aware, that 2 of our cry rooms in our main clinic were negative pressure. We're up on the 2nd floor. When they installed nitrous, they decided to make it safer for a nitrous leak to have negative pressure, so we vent outside. And so from that point on, we felt safe providing ultrasonic scaling in those negative pressure rooms. Then isolating every room. Walls initially were done, and then a second round of construction did doors. And the construction was done with a material called Plycor, which is a plastic material that has corrugation on one side to make it stiff. So this is a temporary construction, but it should hold up for even a couple of years, and then we can look at making that more permanent down the line. Then redesign of our HVAC to create a flow from the entry of the room to the back of the operatory. If we're enclosing the room, then we can't depend on air supply from the hallway. And then provide 200 CFM minimum turnover in each operatory from that HVAC design. And then additionally adding use of other portable devices. And so the principles to consider are, the first, you've got to have a MERV 13 or better main filtrations. That's 99.97% filtration of 0.3 micron particles. And you know, one of the things that came up right away is I started to look at different products, and you know, I was compiling a list and sending them over to the engineers and trying to get them to respond to different features and things. But if we had two possible filters and say I've got a 95% filtration at 0.3 microns and you've got 99.97 at 0.1 microns, clearly yours is better, right? And the answer is actually we can't tell, because there's what happens is that as you get to 0.3 microns in the dip of that curve, that's the most penetrating particle size. Larger than that, then it's largely hitting fibers and intercepting things that are moving through the material. But below that, you've got diffusion, electrostatic forces, Brownian motion that helps catch things. So at 0.1 micron, your filtration is always going to be better than at 0.3. And it increases down towards about 0.01 micron particle size. The key thing is the effective particle size. You know, you got to figure out what's going on at 0.3 microns. And so if you're looking at a product and you can't get a rating at 0.3 microns, then you should really move on. Telling you that their filtration rate is super great at 0.1 microns doesn't really tell you anything. So either they can't tell you, or they don't want to tell you, or they don't understand their own filtration. So sometimes the ad department doesn't give you the information that you need. And sometimes you can get the information in the specs. But you really want to know what the 0.3 micron rating is. And then it's pretty comparable. A MERV 13 is comparable to an N99 mask. And so that's 99.97% filtration at 0.3. An N100 would be 99.99, and 95, an N95 is equivalent to 95%. And then there's also a lot of products out there with additional layers of filtration and protection. So UV filtration, ionic filters, chemical filters, moisture catch filters, and things like that. And the engineers basically said, anything that you can add on in there, that's great. Just run with it. So some of the other things that come into play is obviously a higher airflow is better because you're turning more air over. So the higher CFM's better. Cost, obviously, if it's cost the farm to get, then it might be difficult. Availability was a serious issue when we first started looking at this. Some things were available, some things were available on later order. But probably the thing that we dealt with the most on things that were affordable and available was how much noise they were going to make. And so We ended up getting corner of the room filtration. This unit's called a PureShield, and it has multiple stages filtration. It's a HEPA final filter, but before that, there's a moisture catch with silver ions and copper at level 3 there. And then there's a molecular filter that's basically a bunch of beads that have air penetration to them. And the active thing inside the beads is permanganate oxide that reacts with just about anything. And then a pre-filter that traps out dust. And so those are great. We use them in the corners of the rooms. Initially, what I wanted to have happen is have these for less busy rooms or less aerosol producing rooms, and then using a chairside unit for when things were being produced largely. So I started off with each room having enough for half of the rooms to have the corner units, and then half of the rooms to have this unit, which is called the Air Max. Again, multiple filtration levels there. A primary filter, just larger particles, and then a sterilization filter, a UV plasma filter, and then an H14 HEPA filter, which is the 99.99% at 0.3 microns. And then so our strategy was anything above a filling on our hierarchy should have the Air Max running with it. So the chairside unit going there. And then as we got into it, we started to think about, okay, the clearance time. And so with the HVAC, we hit the goal of having all of our rooms at least at 200 CFM. Most of our operatories are about 12 by 10 and 9 foot high. So that's 1,080 cubic feet. The PureShield can move 425 CFM. And there are different spec sheets out there. And so 425 is the best. It may not produce that. I'll just say one more thing about the design of those. It draws air from all around the unit. It's got that cylindrical filter, and that tends to make it a lot quieter. So it's probably the most quiet of the heavier moving air things, being about under 60 decibels. Anyway, so as we calculate how many air changes per hour, we looked at what it was for the two, and then I thought, well, what about all three? And all three end up putting us into 49 air changes per hour. And there is a fun formula with a natural log calculation in it. It's really not too bad, but you can actually take and calculate the time to the percent efficiency clean that you want. And so the recommended standard from the CDC is the 99% efficiency removal. And so potentially we can get down to 6 minutes on a COVID exposed room and be clear if we're running both machines in there. So subsequent to our initial phase, we're now waiting for delivery so that we have enough for those PureShield machines in the common areas, and one for each room, as well as having the Air Max for the higher aerosol producing thing. So we'll take you now through a couple of things that we made with our changes, what we did with our changes. Our reception was open to the clinic bay, so we're kind of in a U shape for the clinic. This is a 10-chair clinic. And so straight through these doors is reception. And on the other side of that is more operatories. And as soon as we got plexiglass up in front of the PRRs at reception, then we really started, they were really noticing how much more noise was coming in from the clinic side. And that made us immediately think, you know what, with the noise, we're gonna have air coming in there. So we immediately got bid out on getting some sliding glass barn doors to close that area up. And then enclosure of actual clinic rooms, we've got our standard ADEC equipment. And then these are the ply core walls that go over top. And we'll get a couple different views of different things that we had to go around. So in this room, we've got X-ray shared between another room. This door slides and exposes the X-ray so that you can swing it into either room. So there's a slide door on either side. Some of the rooms had a pillar, and so we couldn't always put a slide. So we had these zippered things. The zippers go pretty high, so we got blind handles to put on the zippers so that the shorter assistants could reach. You can see that there's a handle on this middle one, and reaching all the way up to get it zippered so that the thing can swing out. It's a little bit difficult. And then in between our ops, we had sinks. So we just brought out the ply core to the outside edge. So you can still walk up to a divider between two rooms and wash hands there before entering a room. And then every room has its own return and supply of air. This supplies right over the patient's head. The returns at the end of the room. Ideally is if the return is at the floor so that the air flows downward, but that just wasn't going to be possible. And but that does give us a great cycle through so that we're only getting air cycled out of the room and not bringing air from the room out to any other areas. And then here's just a look down the hallway with kind of everything enclosed up again. In the middle of all this, we also were awarded an OHI grant at the fall 2019. And we paused our design efforts early in 2020, and then got this all together and rolled all this into our design. And so we're opening a new clinic in Sholo in 2021. And it'll feature hospital level air handling with negative pressure in each room. So that adds an adjustable extra 200 to 400 CFN. And we'll still be using the corner units, the air shields, and then the air supply, the HVAC for the treatment rooms is only for the treatment rooms. There's no supplying other areas out of that. So turn it back over to Danielle for question period.
All right, thank you, Dr. Wilcox. If you want to stop sharing, please feel free to type your questions in the chat box or the Q&A fields, or you can raise your hand and we'll unmute you. Dr. Wilcox, what a tremendous amount of engineering and thought that has gone into this. It makes me wonder if this is the future, right? As health centers open new clinics, are these the kind of things that we're going to have to be thinking about? Don't see any questions coming through yet. Let me see if anybody's raising their hand. While everyone is thinking of their questions, I'll just ask each of you, is there anything you would have done differently through it all? That's it. That's my question. I know it's time to, oh, we got a question from the audience. We'll take this one. Are the walls / sliders that went up significantly cheaper than drywall?
Yeah, and they use this material when they're walling off an area so that they can work on a construction area and not affect other areas. So it's a material they were very familiar with. our HVAC and other measures was under $40,000, but a big piece of that was the HVAC and time. So my feeling is that, yeah, it's not a permanent solution. I hope that what we end up experiencing is an opportunity to expand at the same time we revise this stuff and make it more permanent. But we could go permanent with this design with a little bit of alteration and have it really nice. In our new clinic, we'll have sliding glass doors in front of the barn door type style in front of the operatories, but it is functional. But yeah, I don't know if you had to frame in to support the drywall, it would be significantly more expensive to do that. It's probably not the drywall, but all the framing and work that goes with that, and loss of space too. This kept the loss of space at a minimum. We're only adding about 1.25 inches to or losing 1.25 inches from the hallways.
Thank you, Dr. Wilcox, and thank you, Kelly, for the question. Okay, we can go back to my question now because while other people are thinking of their questions. So something you would have done differently, or just your biggest lesson learned throughout all of this.
You want to go first, Amanda? That's fine.
Sure, I can go first. I mean, I think there's so many things, just because it was just so new and so much information coming at us all the time. I think one thing that just became really apparent was just communication. We had a large team, and just, there was constant change. And I think keeping people reassured was really important. People were scared and not knowing, should we be going to work? Should we not? So I think communicating, and I think kind of what Dr. Wilcox touched on, just, staying in touch with other directors was so important, so that we could kind of have some kind of level of equivalent, things and how we were reacting, because there really wasn't and there still isn't, perfect guidance on what we should be doing. So I think those were two really helpful things that helped us through. And of course, hindsight's 2020, like we would have probably not have had as much open spaces. I mean, we still have areas that we're not using as much, right? Because we have all these open bays for pediatrics, and it's just, that's not going to be the wave of the new normal, I think. So obviously, but those things we learn as we move forward. So.
Yeah. I think one thing that I would do differently, but I'm not sure that given the exact same circumstances, I would have done any different, was I became convinced early on that the CDC was on the one hand trying to hold up the, you can't be doing dentistry because it's too dangerous, and on the other hand saying, well, I guess at some point we have to do dentistry. And just saying, it's great to go and look at their website, but when you're the one making the decision, sometimes you have to go out on your own. And ultimately, we were jumping ahead of where they were going, and they caught up. And at first that was a little bit scary to think, what's everyone else going to think when we say, hey, well, we're gonna do this. We said, hey, we can do ultrasonic in our negative pressure rooms and have good control. And then once we were enclosed in other rooms, we were able to add in, we have people use PAPRs in the non-negative pressure rooms. But I think the one thing was I felt brave. I would have been better to feel braver. I really held off finalizing our engineering plans for our new construction. That means, we're going to be right up to within 2 months of our timeline for our grant. It'll be fine. And if we had to run over, we could say, hey, well, there was COVID stuff. But I knew where I wanted to go, but I wasn't ready to commit to it yet, because where was the science going? Where should we do? I think the other thing that I would say that isn't so much a do different, but just more of a take home. The construction company that we work with, Love and Contracting, is one of the best companies in anything I've ever done that I've ever worked with. If you called them and said, you know, this spot's a little too shiny, they'd send someone over and dull it down. You know, I mean, literally they would respond and say, we'll have someone there at 6 a.m. and fix that for you. And I was just so impressed with their ability. And after talking through lots of different possibilities with the engineering people, having it all come down to just kind of what made sense for dental, and you know, was it possible or wasn't it possible, was the only question. And by the time we were making decisions on those things, then you know, there was CARES Act funding that we could throw at it, so you know, we're able to get it done.
Yeah, what you touched on, Dr. Wilcox, is a good segue into the question that we received. If you were to already have the setup that you do now when COVID happened, do you think you, and dental programs across the country, right? If that was the norm, would all of the dental clinics been able to provide care as usual, and there wouldn't have been a temporary halt?
Yeah, I feel the answer is yes. You know, there's always going to be things that come along that are beyond the universal precautions, but you know, we keep circling around that. What's the proper universal precaution now? And you know, I don't think we'd ever go to, well, we're fine now, let's just tear that all down and go back to open bay concept. I'm sure there'll be another pandemic, and you know, who knows when this one really ends. Yes, I think that we can turn rooms over. I intentionally didn't get into the PPE side because this was engineering controls, but you know, a lot of times I'd rather, for some procedures, wear a PAPR than an N95 and loops and a shield in front of all that, because it's just a little bit easier. But yeah, I feel like it should never have to stop again.
Yeah, and I think it's going to be really interesting, just in closing before we wrap up, it's going to be really interesting to see the impact. I don't think we truly know the impact of, you know, not doing dental care for a pretty long period of time, what the results of that are going to be down the road. So I think it's going to be interesting, and not in a good way, but it's a good thing programs like you all are out there, just like our conference theme, providing the care that communities count on. So thank you both for presenting with us today and sharing the great work that you're doing. We really appreciate you. Vita, if you are on, if you want to go ahead and launch the first poll. So if you remember when we had you register, we asked for your pre-knowledge. So this first one is we asked you beforehand, what was your knowledge on aerosol mitigation? And now, now that you've attended this session, what is your knowledge currently? So we'll give everybody a minute to respond to that one. Okay, and we can go ahead and move on to the next one. So this will be your post knowledge on innovative workforce changes. Okay, and then last one, I promise, just overall satisfaction with this session. Sorry for the rapid polls. But this information is really important for our HRSA reporting and just for us to have. So, well, everybody is completing that. I'll just thank our sponsors again. Our networking lunch sponsor who sent out the Grubhub gift card, CareQuest Institute for Oral Health. The swag kit sponsor, Cintas. And our overall annual conference sponsor, Arizona Complete Health. We really wouldn't be able to put on a conference without our sponsors. So please check them out, connect with them, learn about the great work that they do and the services that they provide. Okay, go ahead and end that last poll. And then the last thing is just tomorrow's agenda. So we have almost made it to the end. Tomorrow will be the last day of our conference, and we are ending with something I know everybody is always really anxious to hear, and that's to hear from HRSA. So Dr. Jennifer Joseph from HRSA will be providing a health center program update and talking about their priorities and what they're investing in when it comes to the health center program. And then we will get to do a final wrap up of all of our award presentations. You got to see the Invaluable Dental Assistant Award